Hello, everyone. Welcome to our September ICARE Case Conference. I'm Tua Pal, and I wanted to introduce my friend and colleague, Dr. Doug Stewart, who is our guest expert. The focus today is tumor predisposition genes, penetrance, prevalence, and estimation of risk. What's missing from this is the genome first approach that Doug has been working on for the last several years. So Dr. Stewart is a senior investigator in the clinical genetics branch at the National Cancer Institute. He's both an internist and a clinical geneticist with a longstanding interest in hereditary cancers and improving the health and care of people with an increased risk of cancer. He's the PI of a study with Geisinger to investigate the genome first approach in cancer genetics. And he's also an investigator on multiple natural history studies at the NIH and NCI of monogenic disorders, including RASopathies, Dicer1 related tumor predisposition, Maffucci syndrome, Ollier disease, and NF1.
Thank you for the introduction. Yes, I think Tua pointed out, I neglected to include the phrase genomic ascertainment in my title, but it'll become obvious that that's a central part of this paper. So just this talk. So just generally, my interest is in quantification and characteristic of both pediatric and adult cancer risk, and use a variety of strategies listed there, which we will talk about. And I use a variety of approaches listed there, which we will focus primarily on that first bullet, less so on the second two bullets, and then seek to include all of the principles listed there with recognizing mentees, using epidemiology, and really focusing on clinically relevant variation and trying to change management whenever possible or inform surveillance. So just a quick advertisement for our RASopathy study here at NCI. I'm the principal investigator, and you're welcome to, if you have potential cases to refer, either with a clinical or a molecular diagnosis of a RASopathy, with the exception of NF1. There are lots of studies for NF1, not as many for the other non-NF1 RASopathies. You can use the email there, or you're welcome to email me, and I will get you connected. So I want to briefly talk about what we mean about genomic ascertainment and give you deliberately a non-cancer example to illustrate this, and then talk about CHEK2 and PALB2 and summarize some lessons learned. So I suspect many of you are familiar, whether you know this name or not, with the phenotype first model of clinical genetics, where we start with a disease of interest, historically ascertained in relatively, in families and individuals, often through a clinic, often relatively modest numbers. We use statistics and then try to link that phenotype to a variant in the germline, as defined by a variety of technologies there. And again, referring back to my friend and colleague Les Biesecker, he said, this is the ascertain the weird phenotype and then find genotype. And this is something that we really know how to do in the rare disease community, especially as investigators develop pattern recognition skills to identify things either in a patient or on a pedigree. We know how to recruit these patients. And the cost can be modest. We have single investigator in a single clinic. Now, like everything, there are some weaknesses. There are ascertainment biases here. You only see people who have developed the phenotype of interest. Why else would they come to clinic? We also will very likely miss non-penetrant cases because, again, why would they come to clinic if they don't have a personal history of a particular disease? And you may miss rare or unknown manifestations of a disorder, and you may overestimate the severity of the disorder because the only people coming to clinic are those who have consequences. And this is more of a reactive pose, meaning you're responding to the variant after the development of the phenotype. And of course, it takes a long time to develop these cohorts. So then what we're talking about with a genome first approach is an inversion of this, where you start with a variant in the germline defined by a variety of technologies there, use statistics, and then try to identify the associated phenotype, which can be as focused. It can be a single ICD code or a single cancer or as broad as you want, entire menus of ICD codes. Entire health systems are getting into this, as Vanderbilt well knows, and plays off the strength of the electronic health record. This is inherently scalable, and indeed there are entire populations in countries getting involved with this. And this is ascertain weird genotype and then find phenotype. And I list here a variety of synonyms: genotype or genome first, and then there's some acronyms, excuse me, not acronyms, synonyms below. I prefer genomic ascertainment. That's what you'll hear me say. And like everything, there's some strengths. Theoretically, you should be able to see the full phenotypic spectrum, especially at older ages. If a sufficient number of people, you should be able to see a wide range of severity. You should be able to develop better penetrance estimates. In principle, this is proactive. You have the variant, and then you can respond. You can query a single variant, or a single gene, or multiple genes, multiple pathways. And as a geneticist, this gets me excited because there are opportunities here for syndrome discovery and maybe higher throughput. There are some issues. There are different ascertainment biases. In order, at least for the cohorts we have available today, you have to have health insurance to be part of a health system. You have to be interested in research, so forth and so on. Be willing to volunteer. So there, we may see people, different populations through those lenses. This is the only equation I have, but if you're interested in variation that affects 1 in 100,000 people, and you have sequenced 1 million people, which even today is a good number, you have 10 people to study, which I know you can't do a lot of statistics on 10 people. Obviously requires significant infrastructure to harbor databases with a huge amount of exome and genome data. It can take a while to sequence these large cohorts. You need some bioinformatics expertise, especially variant classification if you're doing this across multiple genes. And one of the things that I've learned is you need some data science expertise. Know how to parse the EHR for the phenotypes that you're interested in, how to look for how to handle missing or sparse data. And of course, ICD codes were developed for billing, not for research. And in different institutions have different quirks and kind of cultures of coding. So a certain entity may be coded in one way at one institution and quite differently at another. So if there's one thing I want you to take away from this talk is these 3 bullet points, because I think you'll hear more and more about genomic ascertainment as time goes on, especially for studies like the eMERGE-4, like you just heard. What we tend to find is that the prevalence of pathogenic and likely pathogenic variants is often greater than previously estimated, that we see the penetrance may not be as high as previously estimated, and the phenotype is different. It may be less severe, it may be broader, it may encompass things we really had no idea before. Medicine keeps you humble. It's it's an exercise in humility every day. And one of the things I've learned is we often really don't fully understand the phenotypic consequences of germline variation in a lot of the genes that we thought we knew pretty well. So we've been interested in the genomic ascertainment for a number of years and have worked with Geisinger. And this paper here from Genetics and Medicine from almost 10 years ago was written by the lead author, David Carey, who's illustrated there, when they had put together, as the title says, a EHR-linked biobank for precision medicine research. And they teamed up with Regeneron and started sequencing their biobank on a large scale. This is headquartered at Geisinger Medical Center in Danville, Pennsylvania. It's north of Harrisburg by about an hour. Just a bit of history. It opened in 1915 as Geisinger Hospital through the efforts of this woman, largely due to the efforts of this woman, Abigail Geisinger. Her husband made a fortune in mining, and he died, and she inherited it, the money, and she wanted to do something for the miners who had made the fortune possible. So she had donated money and the land to build the original Geisinger Hospital. And my understanding is that she's buried not far from that hospital today. So this is the map of Pennsylvania, obviously, and you can see the Geisinger clinics follow the stretch of the Appalachian Mountains as they run through central and eastern Pennsylvania, where the mining operations originally were. And we working with them on a genome first approach using their population scale data linked to the EHR. And they have over 3 million people in their health system, and a fraction of that in my code, the biobank with the exome sequencing. This tends to be a relatively non-transient population. There are many multi-generation families with relatively low in and out migration. And kudos to Geisinger, but they adopted an EHR in many years before the rest of us did in the mid-90s. So this has been a tremendous advantage. And as of today, we have over 230,000 exomes done by Regeneron and a contract to look at those exomes. So this is a cartoon that shows generally how we approach these genome first approaches. And we use Geisinger listed there and UK Biobank, which of course is effectively publicly available at very modest cost. And then we've also worked with Bruce Gelb at Mount Sinai on the BioMe cohort. And you can see their numbers and some of the limitations, especially with adult and children's. So in a typical kind of study, again, we tend to focus on clinically relevant variations, so pathogenic or likely pathogenic. We define controls typically as canonical or only benign, likely benign. There are, of course, lots of ways to do this. And again, with our clinical bend, we tend to focus on variation as defined in ClinVar or InterVar, which is an automated tool to do classification of variants. I mentioned AutoGVP here, which is a reference down here with the PubMed ID. This is a tool that's developed by my group that allows permits classification of variants using both ClinVar and InterVar, and it has a hierarchical system of how it weighs classification schemes. It's been a very useful tool for us. And then, of course, we also use IGV and occasionally Sanger confirm things and also look at copy number. And then in our work, again, trying to use epidemiology to the greatest extent possible, consider the important epidemiologically relevant covariates. And so we pull the phenotype from the EHR. These are all, I think, very familiar to this group with ICD codes, lab values, imaging, procedure codes. We have used chart reviews by both genetic counselors and by physicians. Geisinger has a tumor registry that was set up in 1943. And so that's a wonderful resource for our work. And then, of course, there's the death index. And then we rely on our statistical colleagues to keep us straight and honest on interpreting, using the right methods and interpreting the data properly. So I list some of the methods there. And then if we do this correctly, we ideally have genomically ascertained prevalence, the phenotype, a risk, penetrance estimates, and survival. And then as a geneticist, you can nerd out on all sorts of things. You can look at biallelics if relevant. You can look at digenics, a variant in two different genes in the same pathway. And of course, you can look at people who are germline negative and phenotype positive. There are lots of sort of different iterations on this. And so this is a running list of, it's not exhaustive, but it's a lot of the papers we've done in the last 5 years using genomic ascertainment. You can see the theme, of course, is that we focus a lot on cancer predisposition and monogenic disease. And I want to talk about 3 stories today that have either published or in process of being published. So the first was a paper, and as I said, this is deliberately not a cancer phenotype. It's a very simple phenotype, but this was a study. I was fortunate to be able to work with Bruce Gelb, well known for his work on Noonan syndrome. He identified the association of PTPN11 with Noonan syndrome 20 years ago now. And we took this genotype first, genome first, genomic ascertainment, looking at Marfan syndrome and at Noonan syndrome. And Bruce's question was very simple. If we do genomic ascertainment of the variants that we have high confidence are associated with Marfan syndrome and high confidence associated with Noonan syndrome, what exactly is the height of these individuals? And how often are they diagnosed in the EHR? And so at the time, we had 30,000 or so exomes in BioMe from Mount Sinai. And I'll put air quotes here, just 50,000 exomes from UK Biobank at the time. And then we looked at genes that had definitive or strong levels of evidence as per the ClinGen, the relevant ClinGen GSEPs for Marfan and for the RASopathies. And we used fairly standard filtering criteria to identify variants, and then used identified pathogenic and likely pathogenic variants per the ACMG AMP RASopathy rules that Bruce was instrumental in writing, or using the similar, the Marfan variant curation expert panel, their classifications. And then we looked at heights and used z-scores, and then pulled some data from the EHR about how diagnosis and other phenotypic features. And so there are two slides here. We're going to look at Marfan first. If you don't know anything about Marfan, you probably know that these folks, in the textbooks at least, are tall. And they have a distinct appearance, very long and lanky, long arms, very tall, said to be basketball players. And the problem is they get dilation of their aortic root, and it can rupture and result in premature death. They also have eye problems and loose skin and so forth. So, but they should be tall. And that's what the textbooks say. So this is this shows all the data from BioMe and from UK Biobank of all of the individuals in the two different cohorts who had a pathogenic or likely pathogenic variant in fibrillin-1, which is the gene that underlies Marfan syndrome. And you can see the z-score is plotted here. And you can see at a glance that although there are some tall individuals in both cohorts, a lot of them are not particularly tall, and some of them are even on the shorter side. The other striking thing is you can see here the dots in red were those who had a Marfan diagnosis on the chart. And you can see in BioMe and in UK Biobank, it's very much the minority of individuals. And this is not to impugn the clinicians who are seeing these patients. It's just that these have been diagnosed historically a certain way, and either they met the diagnostic criteria or not. And it's only the minority. So you can see there, if you look at maybe not a full-fledged diagnosis, but somebody with a number of clinical features, there were, again, some people who were picked up that way. But you can see a lot, maybe half the individuals had a few features of the disorder. And of course, we're not given a diagnosis of Marfan syndrome. And in the UK Biobank, there was able to look at some of the eye findings here. But again, the striking thing is you don't see this universal tall phenotype that was expected. Now, this is the same sort of data for Noonan, and Noonan is a RASopathy. If you know anything about Noonan, these folks are said to be on the shorter side. They have webbed necks. They have cardiac malformations. Noonan was a pediatric cardiologist, and when she identified these patients 50 or 60 years ago. Anyhow, the textbooks all say these folks tend to be short. And so again, BioMe, UK Biobank, and these are all the individuals, all the data points here for those who had pathogenic or likely pathogenic variants in the Noonan genes. And what I've highlighted here are those individuals, just 3, for whom there was a diagnosis of Noonan syndrome on the chart. And so you can see it's very much the minority of the BioMe participants, and none of the UK Biobank participants harbored a diagnosis. And the other interesting thing is, again, yes, many of them are short, and as a cohort, they were significantly shorter, but there were many who were of average or even on the taller side. And I think this was quite a surprise. So just briefly, what did we learn from this? Well, we learned, I didn't have the time to show you the data, but the pathogenic variation in Noonan was kind of about as expected, but actually we found that Marfan syndrome variation fibrillin-1 was more common than expected in these 2 cohorts. And then the key thing here, and I put it in italics to emphasize it, was that the defined seminal features of both Marfan and the Noonan syndromes may be less penetrant in PLP carriers than previously thought. And I probably should have used the word heterozygote there. And then, again, to drive this point home, only a minority of individuals harboring P or LP variants in both of these disorders were diagnosed in the context of both well-known disorders that were presumed to be pretty highly penetrant. And of course, without a diagnosis, these folks are not privy to the type of care, preventative care, that can extend lifespan and improve health, without a doubt, certainly in Marfan syndrome. Okay, so let's move on to some cancer examples. So my guess is this audience knows well about CHEK2, and it's a low to moderate risk multi-tumor predisposition gene. And this is really a cool paper that came out now almost 10 years ago from group in Scandinavia where they looked at nearly 87,000 people from the Copenhagen General Population Study, recruited in the early 2000s, with data linked to the Danish Cancer Registry going back to the mid-20th century. And what they did was they genotyped these individuals for just one variant, the CHEK2 1100 del C variant in these folks, looked at the cancer data and asked, what was the risk for a variety of cancers? And they had hypotheses that they would see excess risk in breast, which is why the circle is open, as well as other cancers, all cancers. The ones that are a closed circle were more exploratory analyses. And the interesting thing here is, and again, not to impugn the investigators here, the number of observed events was quite modest. You can see there's sort of single digits here, especially in the heterozygotes, and sort of lowish double digits in the more common, like breast cancer, but still significant. So we had a question, and full credit to a former fellow of mine, Sun-Young Kim, who worked with us for a couple of years, went to Cincinnati Children's, is now moving over to Louisiana State University, and said, hey, why don't we take a genome first approach to CHEK2? Let's take a look. And so this is the paper posted on medRxiv. It's under review at a journal. And then the staff scientist who works with me, Jung Kim, has played an instrumental role in all of this as well. And so here we looked at the Geisinger cohort in the so-called Goldilocks build. And we had 167,000 people applied, again, PLP classifications, found almost over 3,000 of them. Removed some biallelics and then defined controls that way. Pulled the same data from UK Biobank, had many more patients, 3 times as large. I actually found a very similar number of CHEK2 heterozygotes, and this is driven by the fact that there's certain variation in CHEK2 that's more common in the Geisinger cohort. Remove the biallelics and define the controls this way. So with 3,000 heterozygotes in both cohorts, it's very satisfying, abundantly powered to see risk for, the cancers listed here, certainly the more common cancers. So this is the data from the study showing the positive findings. So again, this is the number of controls and the number of heterozygotes, and then the odds ratio, and then the SAGE adjusted p-value. And SAGE is a technique that takes into consideration relatedness. And my code, there's a lot of relatedness among these folks, so it adjusts for that. So you can see, not surprisingly, that for all cancers, there's an excess risk for those who harbor a P or LP in CHEK2. No doubt about that, not surprising. Same thing with breast, no doubt about it, not surprising. What may be surprising is that the odds ratio, from the way we did the study, was a little lower than expected. It's been historically published for phenotypically ascertained cohorts. Male genital prostate cancer, again, was positive. And then also we found some signal in urinary tract, particularly bladder and kidney cancers. We found an excess risk of thyroid tumors. And this is a signal here is coming from CLL. Look at UK Biobank, again, same sort of format here, but again, the odds ratios tends to be more modest, listed here. Not surprisingly, increased risk for all cancer, increased risk for breast, increased risk for prostate. Again, we saw a repeat of the signal for both bladder and kidney cancer. And then also an increase, some signal for CLL, although within UK Biobank, there were other hematologic malignancies that were positive that were not observed in my code. But the CLL signal was consistent for both of them. The other thing is, we looked at the time to cancer in both missense and truncating CHEK2 heterozygotes. So you can see the abbreviations here, PMV and PTV. PMV, the missense variants that were pathogenic or likely pathogenic in green, and then in yellow are the truncating variants, pathogenic or likely pathogenic. And you can see those two lines run up, they overlap essentially perfectly. It's clearly earlier onset of cancers than the controls, but there's really not any difference between these missense and truncating variation. And you can see the same thing in the UK Biobank. Clearly significant earlier cancer, but the differences between missense and truncating variant are not apparent in this study. The other thing is we can look at survival, and we did not see a difference in survival in CHEK2 heterozygotes versus controls in my code, and you can see they overlap with controls up to over age 80. There is a significant difference in UK Biobank, but it tends to be in the last decade of life or so, and doesn't really diverge until sort of the late 70s. Okay. The other thing is the all-cause mortality among individuals with cancer was not significantly increased in the CHEK2 hets with cancer versus controls with cancer. So it's not like they, again, from this analysis, don't appear to have more aggressive cancers. So just a summary of what I've shown you from here. We found evidence, not surprisingly, of the breast and prostate, but also in the two cohorts, kidney, bladder, and CLL. The conferred excess risk was low, especially highlight here the truncating variants risk was also very modest. It's typically reported greater than 2. We saw this overlapping risk for truncating and missense, not significantly different, and didn't see a lot of differences in all-cause mortality or in mortality of individuals who have cancer. And then the sort of summary line here, penetrance, all-cause mortality, and all-cause mortality in individuals with cancer, not significantly different between missense and truncating, suggesting that the clinical difference in these variants is less relevant than perhaps we had previously thought, and have clinical implications for individuals ascertained this way. So independent from having diagnostic testing, from being picked up from a secondary findings or a research study like this. So mindful of time, let me just quickly go through the PALB2 and then we can pivot to some of the cases. My guess is many of you know this wonderful paper came out 5 years ago at a JCO looking at risk of PALB2 from a collection of families. The kind of key line here is the estimated risk of to age 80 was 53% with a confidence interval for female breast cancer. And so again, we looked at PALB2 heterozygotes in both Geisinger and UK Biobank, very similar kind of study design. I was fortunate to have my colleague Mark Tishkowitz review the variants for us. And you can see that we're also very well powered in both cohorts based on the types of numbers that we had. And so again, this is the summary slide. This is in preparation. I haven't submitted this yet. I'm working on this. But again, the key thing here, not surprisingly, increased risk of all cancer. This is the signal here coming from pancreas. And we saw a little signal coming here in UK Biobank from skin cancer. This is both melanoma and non-melanoma. You can see the numbers are pretty reasonable. Not observed in my code, not observed in the Geisinger cohort. Not surprisingly, see a signal for breast, see a little hint of seeing a borderline signal for ovarian. This is the female genital, but this is driven by ovarian. You can see it's barely significant. And I know Mark Tishkowicz's talk about a month ago in this forum said that, I think his words were, ovarian was on the cusp of having surveillance for PALB2 heterozygotes. And we see this signal in UK Biobank, not seen so much in my code. And then the thing that surprised me was we saw the signal for neuroendocrine tumors. Again, the numbers are very modest. And the problem is it's hard to replicate this in UK Biobank because of some coding issues by histology, and we're trying to get that sorted out. But I was intrigued by this little signal for neuroendocrine tumors, which of course are rare unto themselves. And then you can see, not surprisingly, the time to cancer for PALB2 heterozygotes is significantly earlier in both cohorts, UK Biobank and in Geisinger, and the time to female breast cancer was also earlier, although our numbers by the risk to age 80 were more modest. And note here that the scale is not the same. This goes to 0.8, and this is the UK Biobank goes to 0.4. I need to fix that for the paper, but it is it is a more modest risk to female breast cancer by the age of 80 using this type of ascertainment. And then the other thing, which really I thought was particularly interesting, was looking at controls here in yellow and this is UK Biobank, no history of cancer, of breast cancer. Green controls, i.e. no PALB2 variants with a history of breast cancer. And then you see the PALB2 with no history of breast cancer, and then how you see an even greater risk of PALB2 with a history of personal history of breast cancer. So I think for PALB2, clearly we need to pay attention to picking up these variants. And there can be some risk stratification based on family history. And I think this plot shows us something that we suspected would be true, but it was nice to see the data show that this is indeed the case. And we also saw increased mortality in both MyCode and UK Biobank for the PALB2 heterozygotes, starting, depending upon the cohort. In MyCode, it was sort of in the 50s, and in UK Biobank, which is the healthier cohort, healthy volunteer cohort, maybe 10 years later. All right, so I'll put the summary slide of the PALB2 here. We see these excess risks for these cancers. We see a hint of a signal in melanoma and other non-melanoma skin cancers in one cohort, but not the other. And same thing for the ovarian. We see this hint of something in neuroendocrine tumors, but there's a very modest observation. It was only one cohort. Did not see an excess risk for colorectal or prostate. And then quantifying the numbers that we came up with were the excess risk appears in both cohorts around 40 for breast cancer. And then at age 80, it's 65 and 44 for MyCode and UK Biobank. That's all cancers, excuse me. And then breast cancer, it's around 37, 38, and 27, which was more modest compared to the previous studies. I want to stop there. I have some summary slides, which we can go through, but perhaps we'd rather talk about the cases. And why don't I just get to my acknowledgements here, and then we can pivot to the cases. So this is the people, especially these women who have done a lot of the work here, and then also call out former mentees and people who have retired from working for my group or from NCI in recent months or years.
Thank you, Doug. That was phenomenal.